السلام عليكم. Good afternoon, everyone, and welcome to our academic activity. So today we'll have a lecture about tricuspid valve repair and the replacement by Dr. Khulud from King Fahd Medical City. Will be supervised by Dr. Haytham Al-Bar. Unfortunately, other presenters will not be able to present today. So, as I mentioned in our group, that's to prevent these incidents from having any more time, we'll ask the successive week presenters to prepare their presentation 1 week ahead, just in case we need to switch the lectures for a reason or another. So I believe we can start 5 minutes past 1. Dr. Khulud, you can prepare your slide. Thank you.
Is it clear?
Yes.
Okay, we'll just wait for Dr. Haytham to come and then we can start. Dr. Haytham, you're here?
Yes. Good afternoon.
Good afternoon.
You want to start?
Yeah, I'm just waiting for you. Can we start?
Yes, of course.
Okay, so today my presentation is about tricuspid valve. It's a quick presentation, surgical approach to the tricuspid valve disease and the indication for intervention and the latest guideline. So first, we're going to talk about a bit about anatomy, then the relationship of the tricuspid valve to the surrounding anatomical structures in the heart. Then we'll talk about tricuspid regurg, the stages, then briefly about tricuspid stenosis, the indication for surgery, and finally the surgical approach. So the anatomy of the tricuspid valve, as you all know, it has three leaflets: the anterior, the posterior, and the septal. The anterior leaflet is the largest leaflet, you can see here, and the septal leaflet is the smallest leaflet. For the posterior leaflet, it has multiple scallops, which is different than the other two leaflets. So the tricuspid leaflet, there are three papillary muscles in the RV holding the leaflets. There is the anterior papillary muscle. You can see it here. The anterior papillary muscle, it holds the anterior and the posterior leaflet. And then the second papillary muscle is the posterior papillary muscle here. And it holds the posterior and the septal leaflet together. And the last one is the septal papillary muscle. It holds the septal and the anterior leaflet. So the annulus of the tricuspid leaflets, it's a complex shape annulus. It's saddle in shaped. It has a high anterior and posterior points and a low posterior septal and anterior lateral points. It's actually a dynamic annulus, which means it can change markedly with loading conditions. And there's a 20% reduction in annular circumference with when there is atrial systole. The septal leaflet is usually fixed and spared from the annular dilation. So when there is annular dilation, it mainly affects the anterior and the posterior aspect of the annulus. When we talk about the diseases later, and when the cause is a functional tricuspid regurg, the annulus itself becomes more of a planar and circular shape instead of the saddle shape. Here you can see it. So the relationship of the tricuspid valve in the heart, you can see that the anterior leaflet, it's close to the RCA. So you have to be careful on this side. The septal leaflet is close to the triangle of Koch. And as you all know, the AV node lies within the triangle of Koch. So you have to be careful here when you're taking your sutures. And there's the IVC and the coronary sinus behind the posterior leaflet. Here also, you can see the septal leaflet, how close it is to the AV node. So moving to the tricuspid regurg, what is the classification and the causes? The cause can be either primary or secondary. If the cause is primary, you can look for if it's a rheumatic tricuspid regurg, which almost always comes with the rheumatic mitral stenosis. So you'll have usually a tricuspid regurg plus or minus stenosis. If the cause is myxomatous, you'll see prolapsing leaflets. You also see chordal elongation and chordal rupture. Another cause of tricuspid regurg is endocarditis. And another one is iatrogenic, which can be caused by the pacemaker leads or in myocardial biopsies. Also, endomyocardial fibrosis can cause tricuspid regurg, traumatic cause, congenital anomaly, or carcinoid syndrome, where there's deposition of fibrous tissue causing the tricuspid regurg. The other classification is the secondary or functional, which is usually most of the cases, more than 80%. The cause of this is that there will be pulmonary hypertension. The RV will dilate, so the annular will dilate and cause chordal functional shortening, thus at the end causing malcoaptation. Like causes in left heart disease, where there is LV dysfunction or valve disease, pulmonary hypertension due to any other cause, or lastly, RV failure due to any cause like ischemia or myopathy. So the guidelines, there was the 2017 guidelines, but recently the 2020 guidelines came out from the American Heart Association with management of patients with valvular heart disease. And they put the stages of tricuspid regurg, they staged it at B, C, and D. And for the B, they defined it as progressive tricuspid regurg. You will see a central jet area less than 50% of the RA. The vena contracta will be less than 0.7, and the effective area will be less than 0.4. The regurgitate volume will be less than 45 ml. When the patient has a progressive TR, usually the hemodynamics are not affected, and the patient will not have any clinical symptoms or presentations. The second stage is the asymptomatic asymptomatic severe tricuspid regurg. You will see the central jet more than or equal to 50 of the RA. The vena contracta will be more than or equal to 0.7, and the effective area will be more than 0.4. The volume will be more or equal to 45 ml. There will be a dense continuous wave signal with the triangular shape, and there will be a hepatic vein systolic flow reversal. Hemodynamically, you will have a dilated RV and RA, and elevated RA with the C wave. In this stage, the patient can have elevated venous pressure, or he can come with no symptoms. The third stage is symptomatic severe tricuspid regurg. The central jet will be more or equal to 50. The vena contracta is the same as one before, more than or equal 0.7. The effective area more than 0.4. The volume is more or equal to 45. And there will be the same as before, the dense continuous wave signal with triangular shape, and the hepatic vein systolic flow will be reversed. For the hemodynamics, is the same as the one before, dilated RA with RV, and elevated RA with C wave. Here, the patient will have elevated venous pressure, and he can present with symptoms such as dyspnea on exertion, fatigue, ascites, or edema. And these are the stages in the guidelines. For the tricuspid stenosis, it's an extremely rare condition, less than 1% of patients in the developed countries, almost systemically associated with the left-sided heart disease, and it's usually rheumatic in origin in 90% of cases. Other causes could be like congenital anomalies, endocarditis, right atrial tumors, or prostatic valve dysfunction. For the tricuspid stenosis, when there is severe tricuspid stenosis, the mean gradient is more than 5, and the valve area is less than 1 centimeter cube. The symptoms that the patient present with, sometimes there is none or variable depending on the severity of and the degree of the obstruction. So the guidelines, they put the recommendations for for the diagnosis of tricuspid regurg. They said in patients with tricuspid regurg, transthoracic echo is indicated to evaluate the presence and severity of the tricuspid regurg, to also determine the etiology, measure the sizes of the right-sided chamber and the inferior vena cava, and assess the RV systolic function. It's also used to estimate the pulmonary artery systolic pressure and characterize any associated left-sided heart disease. And this is a class 1 indication. In patients with tricuspid regurg, invasive measurements of the cardiac index, right-sided diastolic pressure, pulmonary artery pressure, and pulmonary vascular resistance, as well as right ventriculography, can be useful when clinical and non-invasive data are discordant or inadequate, and they class this as a class 2A. The second thing that they recommended is medical therapy for tricuspid regurg in patients with signs and symptoms of right-sided heart failure attributable to severe tricuspid regurg, like stage C and D. Diuretics can be useful, and they class this as class 2A. In patients with signs and symptoms of right-sided heart failure attributable to severe secondary tricuspid regurg, like stage C and D, therapies to treat primary cause of heart failure, example like pulmonary vasodilators to reduce the elevated pulmonary artery pressure, goal-directed medical therapy for heart failure with reduced left ventricular ejection fraction, or rhythm control of AF can be useful, and this is a class 2A. So the timing of intervention for the tricuspid regurg in patients with severe tricuspid regurg, like in stage C and D, who are undergoing left-sided valve surgery, then tricuspid valve surgery is recommended as a class 1 indication. In patients with progressive tricuspid regurg, like in stage B, who are undergoing left-sided valve surgery, tricuspid valve surgery can be beneficial in the context of either tricuspid annular dilation, where the tricuspid annulus end diastolic diameter is more than 4, or there are prior signs and symptoms of right-sided heart failure. This is a class 2 indication. Then in patients with signs and symptoms of right-sided heart failure and severe primary tricuspid regurg, like in stage D, isolated tricuspid valve surgery can be beneficial to reduce the symptoms and recurrent hospitalization, and this is a class 2A indication. In patients with signs and symptoms of right-sided heart failure and severe isolated secondary tricuspid regurg attributable to annular dilation in the absence of pulmonary hypertension or left-sided disease, who are poorly responsive to the medical therapy, who have isolated tricuspid valve surgery, can be beneficial to reduce the symptoms and recurrent hospitalization, and this is a class 2A. In asymptomatic patients with severe primary tricuspid regurg, like stage C, and progressive RV dilation or systolic dysfunction, the isolated tricuspid valve surgery may be considered, and this is class 2B. In patients with signs and symptoms of right-sided heart failure and severe tricuspid regurg, like in stage D, who have undergone previous left-sided valve surgery, reoperation for the isolated tricuspid valve surgery may be considered in the absence of severe pulmonary hypertension or severe RV systolic dysfunction, and this is a class 2B. The indications for surgery for tricuspid stenosis, this is from the 2017, and it's not changed. They didn't mention anything about tricuspid stenosis intervention in the 2020. This is the 2017, like I said. The surgery is indicated in symptomatic patients with severe tricuspid stenosis, class 1, and surgery is indicated in patients with severe tricuspid stenosis undergoing left-sided valve intervention, also class 1. So what is the surgical approach to the tricuspid valve? First of all, the incision, as you all know, median sternotomy is the preferred approach. Then for the cannulation, it's a bicable cannulation with snares. The isolated tricuspid valve surgery can be performed on bypass with a warm beating heart. So how do you expose the tricuspid valve? You make a longitudinal 1 centimeter incision, posterior and parallel to the atrioventricular groove. And you have to be careful here not to injure the SA node. So once you make your incision and tricuspid valve is directly under your vision, whatever procedure you are going for, either repair or replacement, we'll talk about each one separately. First, about the repair of the tricuspid valve. There's the annuloplasty technique. There are multiple techniques. The first one is the annuloplasty technique. It's used for dilated tricuspid valve annulus with the normal leaflet and chordal structure. It reduces the annular size and achieves leaflet coaptation. Other techniques like plication of the posterior leaflet, like in bicuspidization. There's also the partial purse string reduction of the anterior and the posterior leaflet annulus, and this is the De Vega style technique. Then we have the Alfieri stitch, or rigid or flexible rings or bands can be placed. So here for the bicuspidization, it starts from the anterior posterior commissure to the posterior septal commissure. The sutures are tied, obliterating the posterior leaflet. Effectively, you're kind of creating like a bicuspid aortic valve. This is the bicuspidization technique. Then the De Vega style technique, using 2O-proline ethibond or Dacron polyester suture. It's placed also from the posterior. It's placed from the posterior septal commissure to the anterior septal, and the depth of each bite is around 1 to 2 millimeter, and you travel about 5 millimeter. The second limb of the suture is placed through a pledget and run parallel and close to the first suture line, placing it through a second pledget and at the posterior septal commissure. The suture is then tightened You can see here, he started here and finished, and he went around. Then after it's tightened, a ring sizer can be used to help in approximation of the degree of the proper tightening. The third technique is the annuloplasty rings or bands. They do not include the area of the septal annulus, and the size vary according to the length of the fibrous septal annulus. There are many kinds, rigid rings, flexible rings, the flexible bands like the Cosgrove annuloplasty system or the Medtronic Triad Adams annuloplasty ring. So what is the outcome and of these techniques? For post-functional tricuspid regurg repair concomitant with intervention on either or both sided valves, the study done in 2010, it showed that rigid prosthetic rings had at least the least progression of tricuspid regurg, 12% at 5 years, followed by flexible prosthetic rings, 16% at 5 years, bicuspidization, 19% at 5 years, and the last one, which is the De Vega style technique, the annuloplasty, 24% at 5 years. Then moving to replacement of the tricuspid valve. For the valve choice, the age, anticoagulation consideration, woman during her childhood bearing years, social issues may be considered. We don't do the mechanical valves anymore, but this was mentioned in Lawrence, so just for your information. Degenerative changes were less extensive for the bioprosthetic valves in the tricuspid position than in the mitral. And thrombus formation and pannus formation were observed more frequently in the tricuspid position. The tricuspid posterior antiseptal valve leaflets are left in place to preserve the subvalvular structure and help to avoid injury to the conduction system. Then the anterior leaflet could obstruct the right ventricular outflow tract. The central portion of the leaflet can be excised and you can still preserve the chordal attachment. Then a pledged mattress suture using an everting suture technique for the mechanical valves. Here you can see. This picture is from Lawrence. So this is my reference from Lawrence and the 2020 guidelines. Thank you. Haytham, you have anything to add?
Thank you very much. Very, very great and concise, what they call it, summary about the topics. Actually, you mentioned all the things that need to be covered. And the further things is about more information about the tricuspid valve. And usually, especially with the right-sided, I mean with the left-sided involvement, you need really to measure the annulus size and to intervene once it's reached the indication for intervention, because it showed in multiple studies that will decrease morbidity and also mortality for those kind of patients. You mentioned the technique. You mentioned anything? I don't know if anyone has any further question. And each one of those topics, you can take it dissected and speak 1 hour about each one. One question for you: when you do replacement, where you will put your stitch?
If I do replacement, I never seen replacement. I only saw repair. But like, what you mean, where to start?
No. So the trick, especially in cases of when you do replacement near AV nodes, you will take it in the, just maybe 1 millimeter. You need to be away from the annulus at that area, because you don't want to cause heart block. Sometimes even you are not hitting the AV node, but because of the pressure that occurred after the replacement, a heart block can occur. Many surgeons, they will take the stitch on the leaflet, I mean the edge of the leaflet, between the leaflet and the annulus.
So to avoid the heart, conduction problem.
abnormality. It's not like when you do the mitral, you go on the annulus. So the area near the AV node, you need to be away from it. Usually they took it on the leaflet itself, you know.
Oh, okay.
Many surgeon, even senior one, doing this one or this technique.
Yeah, I should keep it in mind. Have you seen Haytham tricuspid stenosis?
No. No.
Okay.
Actually, there is one patient, we did a replacement for him because the annulus was less than maybe 2 or wait, this is 2. Yani not reaching 3 centimeter, like 2.5. So the decision was made that that valve cannot be repaired, and the replacement was carried on for that patient. And he had some sort of stenosis. But when you ask me, is it a tricuspid stenosis, secondary traumatic? No, I didn't saw that. Or
Okay.
classical one. But I saw one case, the patient having rheumatic, actually the MRB decide that he cannot be, this valve cannot be repaired. However, I thought maybe the repair was better for him, but I don't know. Because it was more than 2. They did what they call it a finger test. They inserted 2 finger, you know, if you 2 finger like 2 centimeters, so it was a little bit more than 2 centimeters.
Okay.
So the decision was made not to carry it out. The idea why, because of the rheumatic, when you repair it, the process of rheumatic heart disease will continue. So the repair will fail. This is why they are doing replacement on those kind of patients. However, in the literature showing the repair is better than replacement in many regards, unless you really want to do, you really need to do replacement for a different reason. Other things regarding replacement versus replacement, I mean mechanical versus tissue. Tissue is more common. However, there is a good series, and some surgeons, they are preferred to do mechanical. Even if you went to the guideline, you will see that it's according the same rule apply on the tricuspid that with the mitral and aortic. But we know from the literature and what you mentioned in the lecture, because of the low pressure system, the complication of thrombosis will be high, and you need higher INR as your target.
Yeah.
But when you look at the literature, you will see many paper and series about mechanical, and there is and it showed good result as well. Myself, I will not go with the mechanical, but this is what in the literature. This is why you found this information on Lawrence.
Okay.
So this is about mechanical versus tissue. You mentioned a repair technique. The best technique, according to the literature, annuloplasty, of course, annuloplasty ring. And you know, nowadays even they are talking about the forgotten valve, tricuspid valve, and the idea to intervene on the tricuspid once it's reached the indication. If you notice, even in the guideline, the only valve that you will intervene on, even with a mild but dilated or sign of pulmonary hypertension, is a tricuspid valve.
Yeah.
In the last maybe 5 years, a lot of paper came talking about the importance to intervene, and that will affect the morbidity and mortality on the patient.
Yes.
But this is will need, you know, and this is with the secondary TR, not the primary TR. What else?
You've seen the other
I saw traumatic.
repairs?
Yes, I saw.
Bicuspidization or the Vega.
I saw the Vega, I saw bicuspidization. I saw, you know, when you do in pediatric, if you want to do pediatric rotation, sometimes you do like, it's not like mitral valve repair, which is structure, you resect or triangular resection or something like that. Yani one time we did bicuspidization for one patient, the Vega, one patient actually, he had multiple cleft on the tricuspid valve, okay? So that valve by Proline 6.0, we closed 3 cleft, and there is, I think, yeah, actually 2 cleft and one seems like perforation. Then we apply an annuloplasty ring. It's what it was a little bit strange because, you know, the cleft is a hole, imagine, and even if you put if you apply an annuloplasty, the regurg will occur through that area. So you need the things that you maybe you didn't mention. You need to examine the valve. But before, you need to look. You need to examine the echocardiography to know exactly what's the mechanism of the TR. One, is it because of, if it is secondary, most likely because of annular dilatation. So that will be addressed with annuloplasty ring. But sometimes, as I'm telling you, you will find there is some sort of cleft, some sort of perforation, if there is old infective endocarditis. So you need to address that. Yani even in the repair technique, you can use patch sometimes to repair and address the regurg of the tricuspid valve.
Where do you put the patch?
It's depend. Yani patch usually patch is to be used in cases of infective endocarditis. So you will apply the patch on the hole you have on the leaflet because of the destruction from infective endocarditis. So you will just reconstruct that part of the leaflet to the patch.
So you sew the patch onto the leaflet itself. Okay.
Yes, I never saw it, but I read about it. I saw video about it. I never saw it.
Okay.
Even when I read about it, they mentioned that it's not widely used nowadays because of different technique that arise also nowadays, especially the rings. Dreyfus, one of the pioneer who talk about the tricuspid valve and the indication and when to repair the tricuspid valve. Yeah, other things. What is your cut-off limits to intervene on the tricuspid valve? I mean, in terms of annular dilatation. What's the measurement? You will check on the echocardiography. I'm asking you. Actually.
You mean when not to operate?
No. When to operate? If you have, for example, MR, okay, and you want to operate the tricuspid valve, so what is the annular diameter that you will check on the echo, okay, that will lead you to intervene on the tricuspid valve? This is my question.
I'm not sure, actually.
It's been mentioned in the guideline 40.
They mentioned 40, yeah.
Yes. So this is the one you will check. This is by
okay.
and intraoperatively is 70, okay?
Okay.
70 millimeter, okay?
Okay.
Intra-op, you measure it intra-op, and that was a study done also by Dreyfus, and that 70 is equivalent to the 40 on the echo.
Yeah, pre-op, yeah.
Yeah, then that study, he bring patients with MR and secondary TR, regardless of the degree of the TR. With all the patient, he will open the right atrium. He will measure the tricuspid annulus. If it is 70 and more, he will address it by tricuspid annuloplasty ring. And actually, there was 2 groups, and it showed less morbidity, mortality, and improvement in patient with less progression of the TR. And from that study, actually, the idea of intervening on 40 due to annular dilatation, the cutoff came from there. Maybe we can even bring it more down. I'm not sure in the future. But tricuspid, once you have an indication, please do it. You will see that in all the guideline, in all paper, there is a great emphasis about intervention on the tricuspid valve, according to the guideline. And when you become more and more senior, or you have senior colleagues with you in the gray area zone, and for example, patient with 38 annular dilatation, but for example, with moderate pulmonary hypertension, you can argue that you need to address that valve. However, for the time being, just stuck to the guideline. And when you have a gray area or a case that not clearly fit the guideline, you need to ask to dig more in the history of the patient. If and why I'm mentioning the history, because you want to be sure there is no elements of right heart failure, and you discuss with your senior colleagues about this case as well. This is also another advice I want to tell myself and also telling you about.
Inshallah, Haytham will ask you.
Inshallah. Yeah, I'm planning to open center, so whoever يعني ضبطوني من الحين عشان نضبطكم يعني.
So Haytham, what if you have discrepancy in the measurement between the intraoperative and the echo? So which one would you go with?
I will go with intraop. What do you think?
Yeah, same thing, but
I will go with the intraoperative measurement, because it is in front of me. Cannot be error, yani. You know, you will bring the ruler, and in front of you, you are measuring.
Yeah. And I'm not sure Khalud mentioned or not regarding during the replacement. Do you resect the leaflets or you keep them intact?
She mentioned it. You can, if you kindly, Khalud, if you just remind them what you mentioned. She mentioned it clearly about this point exactly, and she mentioned one of the complication, which is the RVOT obstruction and how to avoid it. If you can kindly, Khalud, repeat what you said regarding the leaflet in the replacement. So the posterior, what she mentioned, the posterior, and if she can bring the picture again. I don't know if she's with us. Or... The anatomy of the tricuspid.
Sorry, you see it now? This one.
Yeah, he's asking you
He's
asking you about the leaflet. What you will do with the leaflet?
Yeah, we usually resect just the anterior leaflet, and we leave the posterior and the septal leaflet, because the posterior and the septal, it preserves the subvalvular structures, and you could avoid injury to any of the conduction system. The anterior one, it could obstruct the RVOT, so you can excise it, the central portion of it, and you can still preserve the chordal attachments even with excising just a portion of the anterior.
But the same rule apply, which you mentioned. One of the MCQ or oral question will come to you as a case scenario about patient you did the tricuspid valve replacement, and post-operatively they will give you a scenario, sign and symptoms of the RVOT obstruction and low cardiac output. So what do you think happened? What happened is the anterior leaflet, because it's long and you did the replacement and you didn't excise it, it will it will cause RVOT obstruction. So the anterior leaflet is not necessary to take it all out, okay? You
just a portion.
Yes, just a portion of it, because as she mentions, like the mitral valve, you want to preserve a subvalvular apparatus, which is a lot of evidence currently in the one came from mitral valve especially, showing that keeping the apparatus will keep the integrity of that respected ventricle. In case of mitral, the left ventricle and the geometry of it, and the same will apply on the right ventricle. And even other leaflet in the tricuspid, you can fold it like you are doing a valve, what they call it, mitral valve preservation, replacement with preservation. Okay, Loy? But one of the MCQ, you will find it in the TSRA, this specific scenario, the RV OT obstruction.
So what you will do in this case, you will go and resect more of the leaflet?
That means you didn't resect at all, okay, the anterior leaflet. So you will check with the echo. It's clearly, this will happen immediately actually in the OR after separation of cardiopulmonary bypass. You need to go on pump, and you need to resect that leaflet causing the RVOT obstruction.
Okay. We don't see a lot of replacement. I'm not sure, is this the current, and all surgeons agreed on this approach, just to resect part of the leaflet, or some surgeons have any other approaches? Not sure if you have seen.
In the replacement?
Yeah.
In the replacement, the tricuspid is not that common. Replacement, I mean. The tricuspid replacement is not that common. I didn't saw a lot of replacement, to be honest with you. But the one I saw, even one with very big senior surgeon, he just resect a part of the leaflet, not all the leaflet. Because why? Especially in the area, or not the anterior, posterior and septal, because he used that remnant to keep his suture on it. And he will take a part also from the anterior leaflet, keeping exactly what Dr. Khulud mentioned, keeping some part of the leaflet to preserve subvalvular apparatus. If there is another methods, and this is what's been mentioned currently in all books, yani. But I'm not aware about any other technique, yani, or what is in your mind. It's to take all the leaflet out.
Haytham, I have a question. You mentioned the case scenario. If you don't resect it and the patient will have a low cardiac output after, then what do? You have to go back and resect some of, or remove the valve?
No. You will not remove the valve, because imagine you put the valve, okay, and the anterior leaflet is coming beneath the valve and going to down inferior, then lateral to obstruct the RVOT. You just come and open a valve a little bit and see where is that anterior leaflet and resect it.
Oh, okay.
ما انت حطيتيها فوقها.
Yeah.
So the best things, either, as you said, you take a part of the anterior leaflet or fold it. Fold it with a suture when you suture the tricuspid valve, that the one you want to replace, and that's it.
Yeah.
One of the cases that also I think you didn't mention it, about the traumatic tricuspid valve regurg. I believe once I send you one case in the in our groups. طبعا, what can cause trauma? Let's take this question. What can cause traumatic tricuspid valve regurg?
A blunt injury.
Yes.
Or when you're taking a biopsy.
Just 1 second. Blunt trauma.
Yeah, or during biopsies after the transplant. Sorry?
Okay. Blunt, if any MCQ came to you or oral question, it's number one valve that will be affected is tricuspid valve.
Okay.
And
then there is like iatrogenic, like from the biopsies or during for the transplant, or the iatrogenic causes.
Yes. So as Dr. Khalud mentioned, this is the cases, and the iatrogenic, especially with a lot of intervention that occurring today. This can be the cause of acute traumatic iatrogenic tricuspid valve regurg. And usually those patients need to have a surgery to overcome this acute events, especially the intervention from the, in one case I saw, because of the TIPS, which is a patient with hepatocellular carcinoma, and they want to stent, and that stent went to the tricuspid, perforation of all the, actually it was destruction of the valve, complete destruction of the valve because of the device. This is one of the causes can happen, and also because of the lead. Sometimes pacing lead, you are placing and you are causing acute perforation of the leaflet, acute TR that need to be intervened on.
Yeah. Also, I have seen that patient, he had the pacemaker lead and he was going for surgery. When we opened to the tricuspid, there was tricuspid regurg because the lead itself was fibrosed to one of the leaflets. So
Yeah.
it destructed the whole leaflet. So you have to replace it. You can't, and you have to remove the lead itself.
Yeah. Also, when our colleagues in interventional cardiology place the lead, the presence of the lead by itself on the tricuspid valve and the location can lead to degree of tricuspid regurg. And the other nowadays is well-known cause of the tricuspid regurg is atrial fibrillation. طبعا atrial fibrillation, you know the mechanism, because of the atrial fibrillation, and that eventually will lead to dilatation of LA, RA, pulmonary hypertension, and all these vicious cycle.
Yes.
But now, even in the literature, you will see, and before maybe 10 years, it wasn't one of the causes. Now it's one of the well-known causes of the problem of the TR. So why also I mentioned that when you have a patient with mitral disease, AFib plus some sort of the TR, fix it all. Because, you know, if you don't fix the TR, let's say you don't have the TR and you fix only mitral, you leave the AFib without intervening on it, if meet the indication for intervention with a mitral, that atrial fibrillation will lead to the TR, which will lead eventually to the bad prognosis. Because another things in all literature, secondary TR after left-sided heart intervention, either mitral or aortic valve, the morbidity and mortality of that redo is higher than when you address it or solve the problem from the beginning.
Okay.
If you have any further question or discussion you want to generate, تفضل.
السلام عليكم.
يعطيك العافية هيثم.
الله يعافيك. تفضل يا دكتور.
اي سلام. انا عندي سؤال بالنسبه لل 40 and 70 millimeter. Is it a diameter or area? And why that?
Commissure to commissure.
Sorry?
70 commissure to commissure.
Commissure to commissure. So why we have that around 80% difference between echo and intra-op?
Wallahi, it was the same question in my mind. To be honest with you, I don't know. What I know when I read about these topics, because it was striking me as well, why here is 40 and there is 70. But what I read in multiple paper, that the 40 on the echo is equivalent, the same as 70 when you measure it on intraoperatively on the valve itself. Maybe because of the folding, I'm not sure, to be honest with you, but this is when I read my conclusion, because more accurate when you measure it by the ruler, and that 70 is equivalent to, and that is 3D when you measure it, while it is 2D when you measure it on the echo. This is my understanding. I'm not sure if it is right or wrong, but what I'm sure about it, I read it in multiple paper. I even discuss it with I didn't ask the senior consultant why there is difference 70 and 40, but they all, when I mention it to them, they agree that 70 intraoperatively by ruler and 40 on the echo.
تمام الله يعطيك العافيه. سؤال ثاني in bicuspidization, is it only involving leaflet and annulus without any deal with the papillary muscles?
Without what papillary muscles?
I mean, only we are dealing with the leaflet and annulus.
Yes.
Nothing to do with the papillary muscles. And
no. From what I read about the technique, you are not intervening with the papillary muscles. You just convert the idea. You convert the leaflet valve to bicuspid valve. And even there is some series that they do bicuspidization plus annuloplasty.
الله يعطيكم العافية.
سلطان إذا لقيت الإجابة حقت 70-40, I'm not sure about the explanation that I gave. This my understanding. You can share it with us, please, or anyone.
Sure, الله يعطيكم العافية.
Okay, any more questions? Luay, I think we are finished now.
Okay, thank you, Khulud, and thank you, Haitham, for this great presentation and discussion. So since we don't have any other...
ما عندكم another lecture, huh?
لا والله ما في للأسف.
Can I suggest something for all of you? I will not present anything, but I just want, if you kindly include, stop sharing.
Okay, 1 minute. Stop sharing.
This is, I will share with you an idea. If you like it, you can start with it. Anyone share screen. في عندي موضوع عن القسم الطبي وأخلاقيات الممارس الصحي. طيب. See, what about if you want to do morbidity and mortality? What do you think about this?
to include it in the schedule ولا now?
زي اليوم مثلا you don't have you can include it any interesting case. It's not supposed to be mortality, okay? It could be mortality or morbidity that happened with the patient. So the idea, you would just come with the background of the patient, small backgrounds. This is what happened, blah, blah, blah. Then you come hospital course, okay? This is what happened. You go like a scenario, the echo of the patients like this. Then the patient was taken cath lab. جيب مثلا شوف زي هنا. You will bring الcath picture and what happened on that, and this is specific to this patient. It's not supposed to be cath. بعدين طبعا هذا كان عنده perforation في الكوروناري في نفس happened in the cath lab على الليفت مين. وبعدين patient unstable وصار له كذا وكذا. وبعدين patient was taken to the OR. صار كذا كذا مثلا في العمليات. هذا الايكو كان intraoperatively after intervening. بعدين تيجي literature review تبدا مثلا بالجايد لاين طبعا هذا مثلا الكوز اوف ديث كان بوست كابج اند ريبير بوست بي سي اي دايسكشن اوف ليفت مين كارديوجينيك شوك. بعدين تجي مثلا جايد لاين ايش يقول عن التوبكس هذا. تمام. هذه الجايد لاين. الستديز small study about the topics what's in the literature about this topic and what we have to do in the future. يعني depend على الكيس نفسها. يعني it will take like 30 minutes and I'm sure you have a lot of cases everywhere. I'm not sure if any one of you was a part of M&M before. I'm asking all the group now. Yani I was part of multiple M&M and I presented multiple cases. Which one of you did the same during the residency?
Yeah, for me as well, I did a couple of
Hello,
cases.
Assalamu alaikum.
Salam.
Hello? Yeah.
Yeah.
I think it's a great idea, Dr. Haitham. We're in Bahrain, me and my colleagues, we're discussing each week a case who got complicated. We're going through the history, the pre-op cath, echo, the operative notes, and then we're going through the ICU course and the complication and what happened. And then we're reviewing the literature about it. Yeah, I think it's a great idea and we're willing to do it. Yeah.
يعني even مثلا لؤي يعني you can either do it on the same day of the academic activity. It can be like a journal club in any other other day during weekend, for example, at any other time. And now with the Zoom, you can do this at any convenient time for everybody. يعني.
It's like a case presentation.
Yes, it's like a case presentation, and you learn a lot.
Yeah. A
A
case presentation and how got complicated and how can we avoid it in the future.
Yes, how to can avoid it and what is the proper management of each case. يعني. I believe.
Yes.
Where is Babgi? I didn't saw Muhammad. He's here. Is he here, Muhammad Babgi? محمد يا شكله مشغول أو طيب شوفوا يعني this is just an idea and you can discuss it. You can take the lead now لؤي and discuss it and you can start it يعني especially now عبد الرحمن he mentioned that he presented some of those cases. So even next week he can present if he like to do that he can present one case and we can discuss it.
Yeah, I'm willing to do it, honestly. Yes.
What about the other? You like this idea or any other idea? Yeah, like today, we have another 2 hours, or you have another 2 hours.
Yeah, it's a good idea. We can work on it and make maybe who's interested to present and make a schedule for the upcoming weeks and arrange for it.
Yeah, especially if it is related to the topics. Yani for example, tricuspid valve. And why I was calling for Babgi because one case I attend for traumatic TR. It was in Mecca. So I can supply or give him the details about the case because he's there. And he can present it, for example. Or any other case. Yani there is a lot of cases that involve morbidity and mortality. You can present it. And as you said, Loai, you present before like this one.
I think everyone of the resident will present one on one day or another, and during his
career.
residency.
Okay.
Yeah. Okay. Any other suggestions or comment from, since we have some time to. We made a schedule for the next journal club. We will be announcing it maybe soon, maybe tomorrow or after tomorrow. So the new way to deal with the journal clubs, that a junior resident will be preparing the topic, and he will be attached to one of the senior guys, R6, R7, R5, so he can help him in preparing the journal club. So we're starting with the R1s. So they have already assigned it to a topic. So one of the seniors will be attached to each one of the juniors. So senior resident expect a call from me to arrange for that, so we can start our journal club. And we'll start the idea that Haytham also mentioned last week or the week before, that we'll have like a debate. We'll try it for like two sessions, and then we'll see how it goes. And if it's liked by all of the residents, we can apply it for the future. But I might ask you, Haytham, to maybe to prepare like a scenario for the guys, so they can maybe prepare the presentation for this. Like maybe if we have a mechanical versus tissue valve, we can just prepare a quick scenario for them, so we can give it to them and they can prepare their presentation.
Yeah, I think the next one, is it regarding AVR versus TAVI?
The next one will be, I think, venous versus arterial conduit.
Okay. خلاص, just what they call it, the one who will present it, okay, they can approach me, so I will give them the material. So the idea that, let's say I will be pro arterial and I will be pro venous. So I will give you the material or like an idea, and of course it's not only me, you may have to come with an even better idea how to convince me that doing venous is enough. No need to go for total arterial. And I will give you total arterial, and you will debate which one is better.
Yeah. So we'll try it, inshallah, early March, and we'll see how it goes. Inshallah, it will be fine.
But the partner, I believe, is better to be AVR versus TAVI. So the one he will say, I'm pro AVR, and the other one he will say, no, because TAVI is the way to go, and because of 1, 2, 3, yeah, they will debate in front of each other.
Mm-hmm. Sure.